So it's a important neglected tropical disease. And I said the decision to administer antivenom is essentially remaining based on a clinical diagnosis, and there are no specific diagnostic tests to for the diagnosis or in the treatment of these patients with snakebite envenomation. So, as I said, I am a complete amateur to this field of thermography. How did I end up using infrared imaging in patients with snakebite? It all started like this. I was actually interested in studying the use of prophylactic antibiotics because many of these patients develop infectious complications. The bitten limb gets swollen and often gets infected. They develop abscess, cellulitis, these kind of infectious complications. So people often use antibiotics prophylactically. But then the effectiveness of these antibiotics has been questioned. So we were conducting a clinical trial of antibiotics to prevent snakebite related infections. So when we had to assess the endpoints, that is to assess the bitten limb, whether it has been infected, that is by serially following the swelling, how the swelling progresses over a period of time. The typical way how this is done is by making measurements. We use a simple measuring tape, take multiple measurements of the leg and the thigh or in the upper limb. But then we realized that this technique of making serial measurements is not sufficiently sensitive. It's not sufficiently sensitive to pick up changes. Clinically, it's very apparent that swelling has increased, but that is not reflected much in these measurements. So we were really at a loss trying to figure out how to document the progression of this swelling. Then what we understood was it's easier to compare the temperature difference between the two limbs. That is more easier. But then the problem is some people are very good at picking up differences, temperature differences by manually palpating it, whereas some physicians are not so good at it. And more importantly, how to document it. This is how the one on the right hand side is a figure typically how we document the uppermost level of warmth felt by palpation every day on physical examination. But then if somebody objectively wants to verify it, how can two people agree that actually it is there at the level it is marked? That's very difficult actually. That's when we started thinking about it. If we are able to make out the temperature differences by palpation, if we can use an objective instrument to pick up these temperature differences, then it will be really good. Initially, what we started with typical an infrared thermometer to make spot measurements, to make multiple spots, then it was totally messy. We couldn't standardize it because the distance you hold, the angle you hold, all sorts of so much of variation was there. We just couldn't figure it out. So that's when we were thinking about using a infrared thermographic imaging, 2D imaging. That might be better. That's what we were thinking. That's when this wonderful paper was published by Dr. Roberto de Medeiros, wherein he described the changes in patients who have been bitten by Bothropus snakes with envenomation and another patient without envenomation. Totally, he described just 3 patients with snake envenomation, and of course, some other scorpion stings also he has described. That's when we really got convinced that this has a real potential to capture. Till then, we were just speculating. Whether will it show up something or not, we were completely clueless because we have never done it before. But when we saw this, we really kind of got convinced that this seems to be really good. This is what we need kind of thing. But then the problem is how we go about doing this imaging. Typically how infrared imaging is done as a completely temperature control environment, very standardized conditions, using an infrared imaging camera, which is a very high spatial resolution. But then if we are looking at a resource poor setting in a rural thing, all these things are going to be simply impossible to do. So then we were in a kind of a quandary, how to go about it. That's when we came across this small compact device, which is so compact that it is smaller than a highlighter pen, which can be kind of attached to a smartphone, and you can use the smartphone to acquire images. And of late, I think you can even process the images using the smartphone app itself. But of course, we do not use the app for processing the images. We just use this device to capture the images. So what did we do? As it was told, I work in the southern part of India in a small area called Puducherry, which is a former French colony. And we encounter four venomous snakes in this part of the world. The uppermost one is the Russell's viper. The second one is the soft-scaled viper. The third one is a common kite. And the lowermost one is the spectacled cobra. The vipers, two vipers, cause whole lot of swelling in the bitten limb, and the cobra bite also causes whole lot of swelling in the bitten limb. The limb gets swollen up. Often it forms blisters, necrosis, sometimes compartment syndrome, and some of them get complicated by local infections. Fortunately, the one which is the common kite, which is third in the row, doesn't cause much of local swelling at all. It causes a pure neuroparalytic symptoms. So these four are the important poisonous snakes which we encounter in this part of the world. So we enrolled adults who present to our emergency within 24 hours after a snake bite. We did a kind of a standardized clinical evaluation. So we did it infrared imaging when they present to the emergency 6 hours later, then 24 hours later. So if they are diagnosed to have envenomation, then we repeated infrared imaging once every day till the time they got discharged from the hospital for a maximum of 7 days. Or if they don't have any envenomation, then they were kind of sent home after 24 hours. So typically we did this imaging at the bedside of the patient, right at the bedside of the patient. Patient was not shifted anywhere. So that's a completely an uncontrolled environment. You have absolutely no control over the temperature. What we did was, what we realized was, when we were trying to do, many times the bedding clothes have so much of background kind of heat emanating from it. Sometimes it's reflective surfaces, all those things. So what we did was, we used to keep just a black cardboard sheet. It's just a simple black cardboard sheet of paper, which is non-reflective, under the legs or under the forearms, whichever part is going to be kind of imaging is going to be done. The most important thing is that we always include the other side for comparison. Other side. Suppose if the patient was bitten on the leg, we do imaging of both legs together. So that kind of standardizes the conditions. Irrespective of the environmental temperature, irrespective of the things, you have a similar part of the body imaged under the same conditions, which helps you in comparisons. So what this, I understand this is called a kind of a comparative qualitative thermography. Okay. So this is how a typical acquired image looks like, raw unprocessed image looks like. That makes it a bit challenging for people to interpret it. So then what we did was, then we kind of imported these images into a desktop computer and used FLIR tools to process the image. So here it shows the temperature window. We adjust the low temperature window such that the background activity kind of gets suppressed, kind of thing. So we are able to see just the limbs in clear relief. Now it becomes very clear. The difference between the two limbs becomes almost kind of a self-evident. So much so even a novice person can say that there is a difference between the two legs. I don't think anybody needs much of a training. That's how I learned it. Okay. So then we also learned that we can use the box tool to find out the, we can define a region of interest and find out the maximal temperature Tmax and find the difference between two Tmax on either side of on both limbs for comparison. So this is how we analyze the images. So this is what typically we find in patients with envenomation. So this is a patient who was bitten by a cobra about 2.5 hours ago on a left foot, which has been kind of indicated by a circle, and it's very clear that left foot there is increased temperature. Similarly, this is another patient who was bitten by a Russell's viper on the right foot 2.5 hours back, and this is another patient who was bitten by an unknown snake on the right foot. These are all typically increased temperature over the bitten body part. We call them as hot spots. Similarly, when it comes to dry bites means either they were bitten by a non-venomous snake, or many a times even when a venomous snake strikes, it doesn't inject any venom into it. So patient won't have any features of envenomation. So this is a patient who has been bitten by a venomous species, but there were no signs of envenomation on the left wrist, and we don't see any hot spot there. We do find some changes. I will come to that later on, but there is no corresponding hot spot. Similarly, this was a patient who was bitten by a venomous species, which is a Russell's viper, but yet he had no clinical signs of envenomation. He was bitten over the right ankle, and there were no hot spot over the right ankle. So these were dry bites. So when we look at the difference in Tmax between the delta Tmax between the two limbs, most often, the difference was less than 3 degrees Celsius in patients with hot spots. Despite having a hot spot, it is important to note that the temperature difference in the Tmax between the two limbs was less than 3 degrees Celsius. In fact, only 5 patients, it was more than 3 degrees Celsius. This is important because it's very difficult, quite challenging for a human observer to touch and make out these differences, whereas infrared imaging is able to easily make it. Am I audible, Dr. Sergio?
Yes.
Yes.
Am I audible? Sorry.
Yes.
Okay. Okay, because I was not sure. I just stopped.
Finish?
Just a minute. I just stopped in between.
No.
No.
Can you hear me?
Yes.
Yes, we can
Yeah.
hear you.
Yes.
Just waiting for you to share again.
I'm just sharing again.
It's just to make it more exciting than there is.
Are you able to see my slides?
Yes, you are
That's
already.
right. We can open the full screen, please.
Yes. Is it right now?
That's
Yes.
right.
Yes. So that's about imaging at baseline when they present to the emergency for the first time. When we did serially follow them up every day, this is a patient who was bitten by a Russell's viper. Within 24 hours, the temperature changes spread to the entire limb. This was a patient who was bitten on the right foot, and within 24 hours, the entire limb is totally warm. Then it's really interesting to note how these thermal changes resolve over a period of time. They kind of resolve in a kind of a centripetal fashion, in the sense that the distal part loses its warmth earlier. So by day 4, almost the bitten area is almost similar to the other side of the body, whereas the proximal part still remains considerably warm compared to the contralateral side of the body. This is how typically the temperature changes progress over few days in a patient which is not complicated by infection. So interestingly, we had a patient who was bitten by a Russell's viper over the right ankle. Swelling progress as usual. By day 3, day 2, day 3, the entire limb was warm. Then we noticed that on day 6, the area where he was bitten continued to remain warm. It did not lose its warmth. We were wondering what's happening. What happened was this patient was discharged home. Few days later, he came back with an abscess over the bitten area, which was drained and Staphylococcus aureus was grown. So because there was an infection and abscess brewing up, the bitten area continued to remain warm. And we also notice some paradoxical thermal changes. So far, I have been telling that when a snake bites and there is and when the venom is injected, it leads to increased temperature. But if I show this image and ask you to guess which arm was the patient bitten, how many of you will say that patient was bitten on the right side? Any answers?
I guess so. Don't know what to say, but let's say yes, right.
Isn't it? Right side looks warmer, isn't it?
It is.
But actually, the patient was bitten on his left forearm, which is encircled. That was really interesting. So the area where he was bitten, the temperature was lower compared to the normal side actually. So this is kind of paradoxical, counterintuitive. So this kind of decreased temperature also we did observe in some patients without envenomation. There were two patterns of this decreased temperature. One was an uniform decrease in temperature through the entire limb, and another one was a localized decrease in temperature. So this is where our entire findings are summarized in the 90 odd patients. So in 48 patients with clinical envenomation, 45 out of 48 had hotspots, whereas only 6 out of 35 patients without envenomation had hotspots. Even those three patients where hotspots were absent, they had cold spots were apparent on in the baseline imaging actually. So if we calculate the sensitivity and specificity of infrared imaging, it looks that infrared imaging, that finding a hot spot at the time of presentation has a very good sensitivity to pick up clinical envenomation and a reasonable specificity to pick up envenomation. Also, we were interested when we are doing serial examination, how it compares with the clinical assessment. So basically, we were looking at the time it takes for the swelling to reach its maximum. So that time was assessed one on clinical examination and by examining the thermal images. There was a good agreement between the time assessed using clinical examination and on infrared images at 24 hours. That is the time point in which half of the patients would have stopped progressing. There was an agreement about simple agreement of about 80% between infrared imaging and clinical examination. Similarly, if we try to compare the uppermost limit of the swelling determined by clinical assessment and infrared imaging, there was an interesting pattern in that many patients it agreed, but in many patients, actually the extent of changes was much more than what was apparent on clinical examination, which is reasonable, which is expected. So why is infrared imaging better than clinical evaluation? This is because the thermal resolution of the imaging device which we are using is about 0.1 degrees Celsius. Whereas even a trained human observer has a lot of difficulty in making out temperature differences below 3 degrees Celsius. Whereas infrared imaging, even 0.1 degrees Celsius in differences, it can easily show. Similarly, the spatial resolution of these images places it far apart when compared to clinical examination. When we are doing clinical examination, at the maximum, we can put our hands over 5-6 places and examine. It's not possible for us to have a centimeter or below centimeter resolution. And most importantly, these images can be stored and some independent person can always kind of try to look at these images. So there is an element of objectivity involved. And we have shown in our earlier work that the agreement between two raters in saying whether hotspot is present or absent is very good. And within rater agreement, the same rater, he looks at the same images in a blended fashion. After a few days, there is consistency. So that makes it really a good tool to objectively document the local changes. In fact, following the publication of our paper, several people around the world have started using infrared imaging in the study of snake bites. In India, Dr. D. Medeiros has published much more interesting findings in patient who has been bitten by micrurus. And Dr. Sergio also has published his findings. So people are really kind of excited in using about this tool in the study of snakebite envenomation. And as I said earlier, last year May, we had a kind of a online meeting in which I was very kind of privileged to listen from Dr. D. Medeiros, and Dr. Sergio has coordinated that, and that's where we are. So what are the potential clinical applications of infrared thermal imaging in the study of snake bites? So when somebody presents with the history of snake bite, and if the infrared imaging is not showing a hot spot, then most likely it's a dry bite or the patient has been bitten by a non-venomous snake. If there is a hot spot evident on infrared imaging, it indicates that venom has been injected into the skin. It cannot say whether systemic envenomation is present or not. That's very important. It says only about local changes. It doesn't say anything about systemic changes. But nonetheless, if we know that venom has been injected, then it helps identify a high-risk group. That's very important. More importantly, the thing which actually instigated our work, it helps to objectively document the local changes, and therefore this could serve as a wonderful endpoint in clinical trials. But there are several unanswered questions. We do not know how early these temperature changes become apparent, and we do not know the local changes, whether these similar changes are found in bites by other species like great bites or other non-venomous snakes like non-front fang colubroid snakes. We do not know. More people, more studies from different parts of the world are really needed. And as I said, there are some patients where there is a hotspot which is evident, but they don't have clinical envenomation. Possibly a small amount of venom has been injected. So what is the relevance of this? We do not know. Similarly, we have to study closely about the importance of the paradoxical thermal changes which have been described. And it will be really exciting from an individual patient care point of view if infrared thermal imaging could flag early the development of local complications like an infection or a compartment syndrome or extensive skin necrosis. So that is where we are. And before I end my talk, I would like to express my gratitude to my postgraduate students, Sabita, Akinchan, Aditya, and Vishnu, who have been working on snakebite envenomation. And Sabita was the student who worked specifically on infrared thermal imaging. And once again, I thank for having invited me to share my experience with you. Thank you.
Congratulations, Professor Kadhiravan. Let me do some questions before Sergio, because I know Sergio will have many experts questions, so my questions are more basic ones and very fast. Professor, how are you excited with this research? And are you using this in your practice? Are you convinced that infrared image came to change the game here with snakes? So are you using these results in your practice in India? How is real life with this technology for you today?
So we have not kind of taken it to practice because people are not really convinced actually.
No.
Not convinced. Yeah. That's because why I will tell. Because if somebody is bitten, typically they do blood clotting, it's assessed. If whole blood clotting, the test becomes abnormal, but I don't see a hot spot. My inference would be that the whole blood clotting test is known to have a false positive. False positive, because there are so many technical errors involved in assessing the blood clotting. That's false positive, but clinicians are not comfortable not to give antivenom. They are more cautious. They said better I give antivenom rather than withholding it. So it's variable actually. We have not kind of translated. It's still in research mode only. We have not translated into practice, honestly.
Oh, but you need to put this on practice as fast as possible, Professor.
So
The time, the experience, and seeing case. Sure, in the beginning, it's good not to believe in wow you see, because there's a learning curve, but after it becomes more easier by the time. And I like it that you started doing the images of both legs, all the legs. So it's very important, because the beginners, most of time, they just do the image on the place of the bite, and it's a basic error for the beginner. So congratulations, you show all the images, and no mind the resolution. Sure, if you have more resolution, it could be more easy to identify, but the results, the measurement must be the same if you have a calibrated equipment. So the region of interest will give the same results if both equipments are calibrated. So, but the most important is the partner finds that you show. The cutoff value is very important to us. And sure, there's a lot of research to do, but congratulations for your team. You keeping open these doors. We started here with Professor Medeiros, that looked at me at São Paulo University, and he came, I will do your course, but I just interested on the snake bite. So, okay, let's go, come on, let's see. And he was very fascinated with the results. And after came Sergio from Uruguay with a big experience and the same hour of Medeiros. And so here I'm seeing a great team of researchers and many publications in the near future. Congratulations. It's with you, Sergio. Next questions.
Okay. It's amazing sharing information, Professor. And I ask one question. How impressive your colleagues, medical colleagues, inside of bedside and point of care, why perhaps see clinical things and, okay, no swelling, more or little edema, no necrosis. And if you see the infrared images, oh my God, look at that, the proximity inflammation. What is your experience about others no wet or no wet thermology, infrared imaging in bedside?
So typically it's a totally new thing, completely new thing. Okay, so I can understand it's people are skeptical, people are a bit suspicious. The best are to be this one. People are not comfortable. People are not comfortable. They go by their clinical intuition. This is what we have been doing so long. How can I say most important thing is that if it shows a hot spot, it's okay, no issues. But when the blood test is abnormal, but there is no hot spot, that's where the problem comes. Clinician thinks, oh, blood test is abnormal, because that's what they have been using for so long. The blood test is abnormal, but your infrared is not showing anything. It means that the problem is with their infrared image.
Yes.
But then we have done more studies to show that actually there are problems with the blood test. There are problems with the blood test. Our subsequent work recently only it was concluded actually. There are problems with the blood test, which has a lot of false positive. Even when you try to do in a very standardized way, it gives lots of false positive results. So that's where this can really help cut down. My real kind of you can say dream or whatever it is actually if this is deployed in a very peripheral rural setting where there is no access to antivenom or the antivenom is very limited available. They can take a photograph. They can see if something can be developed which can give an automatic interpretation. Then they can decide whether should I give antivenom or not. So I'm actually really not looking at a proper teaching hospital setting. I am trying to look from primary care, rural setting. I'm trying to think whether this can be kind of these findings can be translated to that setting. I'm not much bothered about a hospital setting because it's very difficult to change the mindset of people.
Yes, it's a very interesting because perhaps in Uruguay, the last month, and translated a patient, a pediatric, from the north of the country, around 6 hours from emergency care, and we occupied 3 days intensive care unity, and the thermal imaging by bite from microbes is safe, no inflammation. It's a dry bite and very expensive. Occupied 3 days of intensive care for $4,000 per day. Look at that, the importance of use it in point of care thermography for the first 6 hours. This is need emergency translate, or this is perhaps standing by, not, and others therapies. It's very interesting, and congratulations for your Sabita from dry bites. It's inspiring us for others research in Uruguay. Thanks so much.
So may I ask a question? This microears, do you get local swelling? Does it cause swelling?
No. The first time for microbes, swelling, not swelling, or only pain, and the bite, to bite. It's a little on the hand. Yes, pain, not swelling, and over translate for perhaps user of antivenom. Uruguay, we not dispose antivenom in emergency rooms. We need call for Butantan for transporting for air, for helicopter or air, and from Uruguay. And no necessary use antivenom, but occupied 3 days from intensive room. And the professor of the pediatrics intensive care used thermography about on the protocol from the last 2 years and asked me, Sergio, if you use it the first time or the first 12 hours thermography, don't need occupied this unit care room. I think your research is very important for opening your mind from the rest, toxicologists and medical, from the frontline emergencies. Thanks so much again, Marcos.
Honestly, I do not know what happens in microears bites because we have something similar, the crate. Crate, absolutely no local changes. It doesn't cause even a little bit of swelling. Even patient doesn't know whether he has been bitten because the fangs are so fine and it doesn't produce any local change. So and we have not studied that species actually. So that is a kind of a caveat. I do not know whether that is the case with microears also. I do not know whether microears really causes a hotspot. It's quite possible. Only cytotoxic species like vipers and cobras, they only cause this hotspot. It's possible there are some snakes which are purely neurotoxic, may not really result in a hotspot. So it will be really difficult to say at this point, actually, without much data, whether we can use infrared imaging to decide whether to give antivenom or not in microears or freight for that matter. So we don't have data.
Yes, and from the sponsor you ask, Medeiros described in your paper 6 hours and 12 hours ago after a bite from a cruise described buff and change and buff and hands because neurological system, and 6 hours is the and buff not a very hot spot, but a different change for a strange comportment from the bite because it's more systemic and not very local with the bottles, perhaps.
We have a new expression now. Instead of point of care, point of bite. So infrared imaging, point of bite, to understand what is happening. So, I want credits for the next publication. But it's amazing because anything that you use infrared imaging for is to do wounds, could be snake wounds or trauma, anything, wounds. It's amazing because it's so clear. You can do your treatment more fast, more early. You can identify more early the things, what is happening. So you anticipate the situation, and for us as a doctors is strange because we're not for many years we didn't see how it was possible to see the evolution, the prognosis of the wounds, and now we can see it's a real bite or infection or complication, or if there's a reaction of the treatment, if treatment is right or not. So we have much power on the hands, and sure, we need to define the limits of that, but it's something that came to be introduced to stay in the medical practice. Infrared imaging on wounds, especially bites, is very important. So I have no doubt about that. So sure, we need to increase the numbers now, the numbers of patients, the number of results, and also sponsor anyone that have interest on this, on to spend these ideas and put this on practice to save lives. This is the most important here. We are talking about save lives, not just a lab researcher, but we are worried if people don't suffer from this with our nature friends. Yeah. Thanks so much, Professor. Does anyone have any question? I don't know if we have Ken Marcella. I don't know if he has interesting history of a horse that have a snake biting.
I have a question of the doctor.
Yes, go ahead, please.
In the United States, antivenom is excessively expensive. We're looking at the initial administration of 6 vials, and we're looking at $80,000 to almost $200,000, and many insurance companies will not cover the delivery of antivenom. Is this as expensive outside of the United States? And does infrared imaging help to reserve the extent of antivenom?
Yeah. So fortunately, in India, it is not that expensive. It is. I think in our paper we had put it's under $100 US dollars actually. And we do not use monovalent antivenoms. We use polyvalent antivenoms. And I remember you referring to that copperheads are more common in your setting. And I believe that copperhead causes a whole lot of local changes, whole lot of local swelling, blistering, all those things are very common in copperhead envenomation. In
Yes.
that case, if somebody has been bitten by a copperhead and we don't see a hot spot on imaging, then it's very unlikely that some amount of venom has been injected. So in that case, it might be wiser not to give antivenom. But then there are detractors who say that sometimes it injects directly into the veins. Therefore, you get systemic envenomation without much of local changes. I have my reservations about that point. But that is one aspect worth pursuing. That is whether we can we safely withhold antivenom in copperhead bites if there are no changes on infrared imaging. Because we know very well that copperhead causes local changes. So the real interesting question would be that would it be safe to withhold antivenom administration if infrared imaging is normal? That will be a really thing which will be really cost saving university, I believe.
This is Dr. Marcellus. I really want to thank you for the presentation. My experiences with horses, I'm an equine veterinarian, and we see snake bites in horses quite frequently. The majority of the bites occur on the face and nose, but in my experience, most of the bites do not have envenomation. I was taught that snakes sense the size and the aggression of their attacker, and some of the bites are just defensive. What we see predominantly is massive swelling and then necrosis, and we're dealing mostly with Pseudomonas infections in the site. Thermography has been very beneficial. If the bite is unobserved and you are presented with a horse with a fairly swollen head, sometimes the areas of the bites are so enclosed with the swelling that you cannot see that location, but thermography will give you an indication of where that is. And within 2 to 3 days, you can use the thermography changes, predominantly skin necrosis, to begin a more rapid dehiscence and more rapid surgical debridement to increase your healing time and remove some of the tissue that has been damaged and is still harboring a lot of the infectious process that's going on. So I found it beneficial in that aspect. We do have anti-venom here, and it is available to horses as well, but the sheer amount makes it mostly in something that's not necessarily going to get used. But the vast majority of horses don't die from snake bites, but it is sometimes a lot of tissue management more than anything else, and thermography does help with that.
That's really interesting. Actually, I'm not familiar with the first time I'm hearing. That's really interesting. Thank you, Dr. Marcella.
Thank you. Does anyone have any more questions? No? Okay. So people follow us on the YouTube channel. If Professor Kadhiravan authorize, I will put this video on YouTube for free for people to have the opportunity to know your work, your research. And
Sure, with pleasure.
Thank you. It's a pleasure of us too. And we have a WhatsApp community, so anyone can take part. And also we have a podcast and Spotify where we put some presentations and also the topic. So American Academy of Ophthalmology is academic society, and we are very happy because we are opening the doors to increase, to invite more people that have interest on infrared imaging. So I hope in the near future we can you can join with us in a meeting or in a face-to-face at US or in another country. So we are open for any kind of opportunities to change acknowledgement and save more lives. Thank you everybody to the medical minutes today, and see you on the next Saturday. Bye-bye. Thank you so much, people. Thank you.